Our clinics, like how common is this? So in 2000 in our own clinics here, Heidi Bauer and Michael Rodriguez and Eliseo Perez Estable did a study. And in women's clinic, family health center, and what is now the Richard Fine People's Clinic, which is GMC, 15% in the past 12 months for physical or sexual abuse, basically. And 51% lifetime. So full half of our women patients are coming here have at some point in their lives been. The risk factors that, does anybody have a sense of?
So this was only women?
This is only women for those clinics, yeah.
Okay.
Do people have a sense of what are some, I mean, it's just common for everyone, but do people have a sense of what are some of the risk factors for higher prevalence communities for IPV?
Risk factors for IPV?
Like demographics that are sort of higher risk.
Employment, like financial stress, unemployment.
Yeah, so
substance
low
use.
income definitely increases prevalence. Yeah, so you're saying trans. Yeah, so I mean, they didn't even fully study that in this national study, but yeah, the prevalence of violence for trans folks is literally almost, I mean, it's astronomical. So interestingly, bisexuality turns out to be a much higher risk group than lesbian or gay. Like for both men and bisexuality turns out to be, and we don't really know why that. It's just an association. It's not, known to be positive in any way, but in the national data, bisexuality and multiracial are the two categories that are coming out, plus income, to be sort of higher prevalence populations.
Multiracial more than
So yeah, different ethnic groups, different prevalences that they've gotten. There's never been like consistent relationships between specific race and ethnicities and higher prevalence. Actually, it's much more correlated with income actually than it is with race and ethnicity. But patients who self-identified as multiracial had a higher prevalence. There's a really good CDC, I mean, I can probably pull up my computer, there's a really good CDC infographic that goes through all the different communities and like how common IPV is. Do people have a sense of, for IPV and sexual assault, how that relates to age, especially for sexual assault?
I mean, yeah, I
It's really
guesses, but I'm not, yeah.
Yeah, so sexual assault is basically a problem of youth in our country. So 78% of sexual assaults occur before the age of 25. So we are nowhere near starting young enough in talking to people about issues of affirmative consent. I know this actually because of the work that I do. My daughter has become a magnet at her high school for sexual assault survivors coming to her for assistance.
I made the mistake of trying to read that Girls and Sex book. You started reading that?
No, which one is it?
I have to look up the author.
I just
started
heard her
reading
interview.
The really
Oh my
famous
God.
author who writes about women.
Ornstein.
Yes, Ornstein. Yeah,
Oh,
it's really upsetting.
oh, it's completely surreal.
Our kids are living in a porn rape culture
Yeah.
that we did not, if we grew up without social media and without all this internet, did not grow up with.
I mean, just like the mentioning this morning about oral sex was like, just, it's completely shifted. Like, it's just become something that teens, that girls are giving blowjobs to, and it's only that direction.
Right.
There's no anything else.
Yeah, her article was really upsetting in the New York Times. She put a summary article of her work in her book. And it's all about, how much kids are also learning about sex from porn.
Right, but that's what they think is like the manual.
Well, like
Right.
similar to what I think it was you were saying about trouble finding common ground in language to talk about consent
Right.
with one client. Like that she talks about how finding language and talk about pleasure for adolescent girls. It's like not even on the
Right.
agenda. It's not on the radar.
Disclosure is not in the goal, but we want to increase safety, we want to increase empowerment, reduce outcomes, and actually, I think we should view this as like a major intervention for healthcare staff that are being affected by IPV. When I talked to the woman in the state of Pennsylvania who set up all the domestic violence hospital partnerships, she said that in every single hospital she put a DV advocate, the staff utilized the person. So I feel like our programs are for all of us, So screening does actually, though, increase disclosure rates, and I do think the better it is done, the better disclosure rates are. If it's done well, like you do it with the patient totally alone, like this, you just forego it if you can't get the patient alone. We need to all have procedures whereby we know how to separate patients, and we say it's just a policy. Like on L&D, I was saying, like Kaiser has a room alone policy
we do
for
that.
L&D,
I
right?
always have a card for this, that they're not allowed to.
That's, really, I think a best practice. And if someone really feels strongly that they don't feel safe with the healthcare provider alone, hey, Eddie. Yeah, of course. If someone feels like they don't feel safe with the healthcare provider alone, I wouldn't necessarily like force the issue at first, although I'd try and figure out what's going on. But anyway, if done alone, professional interpretation, non-judgmental, this is a really hard issue with interpreters. I've always wished that we would do trauma-informed care training with our interpreters. I feel like they experience some of the highest burdens of trauma. Because they are listening to these horror stories, but like it's totally different listening to a horror story when you can like look at someone's face and you can have that human connection, but to listen to just like this voice and you don't have the person in front of you, they sound really traumatized to me, the interpreter, so I think that's a systems issue we should address.
Are the interpreters here that are part of DPH, do they get to go through the trauma-informed care training?
I don't know, that's a really good question. I feel like they should have their own special session unto themselves. Because I've actually now started to like listen really carefully to the interpreters' voices, and I've started to tell them, like, I told this guy who gave a cancer diagnosis the other day, that was really hard, like, you made a huge difference in this patient, in front of the patient. I said, you did a beautiful job translating, and like that made a huge difference for this family, and I just want to like thank you for this, because it's really disembodied work, right? And so this is really hard to get the interpreter to interpret it the way you're saying it. I had a Russian interpreter once that went off on this long thing, and I like asked her, like, what in the world did you just say to the patient about IPV? When I just said, did your partner hit you, hurt you, or threaten you, right? And she went on, and she was like, I told him it's a crime, and it's illegal, and the police can arrest your partner. I was like, whoa. So yeah, professional interpretation, working with the interpreter well, it increases satisfaction. It's often not done well. The mistakes that are made are people not looking at people's faces, people doing it in front of the partner. I just shared that you said your partner was screamed in front of you, was asked a question in front of you.
You're safe at home, right?
Yeah.
To both of us. Right?
I'm going to answer that for you.
And then she giggled and she goes, I have to ask.
Right, that's how it's being done. That's like
2
how
weeks
it's
ago.
being
Wow,
done.
you see?
Yeah, that is how it's being done. And actually, like I will say that when I experienced my own vicarious trauma, I found myself doing that. Like, your partner hasn't hit you, right? Like, whoa, like even out of my mouth, right? So, here,
Well, I think I think one challenge is in a setting, in the family health center, we do family visits, and then at Hive, we're trying increasingly to invite partners into care, partly
Right.
because it's really motivating for partners to get their own viral load, get on meds and do well with their meds, to be a part of the prenatal care for their partner. So, it has been coming to my mind a lot that we then, if that becomes the routine, then how do you
Right.
rescreen? Like many of those women we've already screened.
Right.
But it's so evolving. Relationships
Right.
are so now you're a family with a new baby at home, and we're doing a visit, and we're not necessarily re-asking with the partner, with the woman alone.
right.
We're kind of going on our old information from our intake a year ago before they had an infant, and You know, so it's like you have to build it in, but you have to build it in again and again.
And you have to build it in again and again, and I will say that there's only like kind of one paper out there that I know of, I haven't looked in a long time though, that was about, is it safe for you to be the provider for both members of a couple? And this paper concluded yes, but actually I had a case that gave me great pause where a mentor of mine handed off a couple, splitting them up, giving the woman patient and giving a different provider the male partner in our clinics, and the patient told me that she was experiencing the whole time she was seeing this other provider, she was experiencing IPV, and that she was like, I know she was like an amazing doctor. I know that she had like the highest ethics and like would never have said something, yet I just didn't feel safe.
Yeah.
And she says, like, this whole time I've been seeing her, this is what's been going on. And I just couldn't, because she was his doctor too, I just like couldn't do it.
So is your gut kind of, it's better for members of a couple to have different providers?
I think it's helpful.
Yeah.
I think it's, but Family Health Center, like PEDS is doing, I think that the pioneers, right, like Family Health Center and PEDS, I think have a lot to teach us. And I think that that's why this whole topic of non-disclosure-based health is really important too. Because what the Futures Without Violence, which is sort of leading this with Liz Miller, this new focus on like sort of universal education approach, is if you screen and then somebody doesn't disclose, we don't spend time educating that patient about this topic, right?
A missed opportunity.
But if instead you start with like universal education, then regardless of whether the patient ever experiences that in their life, they're like, oh my God, I can bring my friend, my cousin, my aunt, my, you know, like back, right, to this provider. So yeah, obviously compassionate body language, willingness to hear yes, totally behavioral terms. No, never the word abuse, never the word rape. Really forced sex, you know, trying to convince you to have sex that you don't want to have, using just behavioral words and not that. And then we can discuss more limits of confidentiality, which especially comes into play with adolescents. The universal education approach. So I have 2 slides about this, and I'll start with this one first. And has anybody heard about the Liz Miller reproductive coercion study in Planned Parenthood? Yes. So
I read it.
yeah. So basically, what they did was they educated the medical assistants to give a pre-written script to say it to the patient, and the medical assistants would say, "We want you to know that we're very aware that sometimes partners can mess with your birth control. They can poke holes in your condoms, they can throw out your pills, they can try to force you to get pregnant when you don't want to get pregnant. And if that's happening to you," so first of all, they said out loud, we know this kind of thing happens, right? And then they said, if that's happening to you and you would like a hidden method of birth control, we can give you hidden methods of birth control like a depot shot or an IUD with the string cut short. And you can talk to your provider about all of these issues, right? So I asked Liz Miller, did disclosure increase? Yes, of course it increased, right? Like they were primed to know that this clinic knows that this kind of thing can happen. So yes, people definitely disclosed more about what was going on. But far in excess of the disclosure rates, people actually asked for, you know, hidden methods of contraception. And then once they did, and they did a study, sort of the patients before and after, pregnancy coercion was reduced by 71%. Just by basically that medical assistant script. So my hope is that every time we start to ring patients and the provider works with patients, we will be giving preventive scripts to people, and we'll be telling them, we could even say to them, you know, because they've already come to clinic and we now are going to have a rise, right? So we could even say to them, even if you don't want to talk to us about that, we can call the La Casa de las Madres advocate down to clinic if you prefer to talk to the advocate, right?
But they also have an option of not talking more about it at all, just getting that backup method?
Yeah.
So some of the women just, they wouldn't even
They didn't,
necessarily.
there was way more getting of the method than there was disclosure.
Wow, that's
Yeah,
interesting.
so that's,
Great
so
idea.
this is the basis for this new approach. One, that we know screening was not occurring well. People were doing it like happened to you and your partner. And two, that you were only then giving the preventive education if the person said yes, when like actually tons of people aren't telling you yes. Some of these people, this might happen to them in the future. It might be happening to their aunt, right? So this is giving the preventive education. And so you're providing preventive education about, we know IPV exists. We know unhealthy relationship exists, and this is how it can affect your health. And then to go one step further, which really helps patients, is making it relevant to that patient's health problems. So that's where our lightning round is going to come in. So and then this is trauma informed, right? Because it says to the patient, this is how you get help, or the thing you want to get, even if you don't want to ever talk about this, right? And that's also comes up with us putting safety cards in the bathrooms, right? Like all those things that we should be doing that's like takes a year and a day to get like the hospital to consent to having like safety cards in the bathrooms and stuff like that. That stuff is life-saving because people will not tell us, but they will take that card, right? We're going to try preventive scripts. You're a game, Monica. You just got a resident. Okay.
Okay, so the situation is, a patient on insulin has unexplained low blood sugars. Okay, so this is
This is
we're
from a real case.
Okay.
So you're assuming, with every single patient, you're assuming that IPV could be happening. And so in order to introduce your screening, and I'll skip to screening questions that we use here for DPH, has your partner ever hurt you, hit you, or threatened you? Has your partner or anyone else forced you to have sex or do something sexually you didn't want to do? Your partner or anyone else tried to force you to get pregnant or interfere with your birth control? These are those questions we have scripted in our EHR, which I will come back to you at the end of this week and send you screenshots of exactly where it is, because we just rebuilt it. And it's, if you don't pull it in the right way, it's horrifically complicated.
This is an ECW.
Yeah. So
For every what visit? For every primary care visit or every?
forever, whatever you decide your clinic's policy is, and I would recommend at least once a year with
Yeah.
each patient. But we use them for men too. So these are some direct questions, but what you want is a preventive script, and ideally, the Futures Without Violence is having people bring their cards are just too high a literacy level for us, but they're having people bring brochures and cards into the room and saying, I'd like to share this with you and explain how relationships can affect your health and how violence in a relationship or an unhealthy relationship can affect your health, and then make it relevant to the patient's problem. So I'm just saying, the more you can make this screening relevant of like why you're bringing up this topic and like why you're worried about it, the more it makes sense to the patient.
And these are screening questions that the providers have asked, not the MA before. Like,
I don't think, I have
this
to,
seems-
no, I don't think this should be done by the medical assistant, except that I will tell you that I know that in our system, every clinic has a different culture. And so at Silver Avenue, there's an MA who's a survivor of IPV who has taken a huge leadership role, and she's just getting tons of disclosures. I mean, and she just has taken it upon herself that like she gets how to do this, and she knows to shut the door and do it alone. But that's going to be like most of our medical assistants don't really, sadly, get a very private space with the patients. Just like how would we make these relevant to the patient? So the patient has low blood sugar unexpectedly. So you screen for food insecurity, that stuff already. Right. horribly. This is a real case from one of Dean Schillinger's patients who had been hospitalized with hypoglycemia and had been screened for taking her medications inappropriately herself, like not understanding the medications, food insecurity, etc. And finally, after years of seeing her, when he went up to the hospital room, after they'd done an enormous amount of testing and hospitalization, she finally revealed to him that her partner gave her the medicine and used to inject her with too much insulin.
Intentionally?
Intentionally.
Always, okay.
Oh, intentionally, yes, to make her ill. And, it's a way to control somebody, right?
Leigh, when you ask these questions directly, do you feel like it's unnecessary to put a time frame into it because they know that you're talking about their current relationship? Or does that not matter?
I think that the big health systems, want to try and limit this. And so they always are in the past 12 months, has this happened to you? I prefer to say ever, to leave it open for the patient to choose.
Well, it implies if it's ever, there's a chance it's going to happen again, and it's the same partner, and
Yeah.
there's just so much more information.
I mean, the people around the table here may curse me when they see the ECW screen and it has past and current for each question, right? But I'm just you'll just fill out whichever question you asked. And if you only asked, I don't have time always to ask, to delve into the past in a big way. And so I'm just it's fine if you only have time for the current. That's the more relevant to the immediate healthcare. But people have all sorts of injuries and horrible health problems related to past abuse that you don't find out about. A lot of head trauma. Okay, and now we know that strangulation causes traumatic brain injury, right? It's causing tons of blood vessels in your brain to bleed as if you had an impact injury. Strangulation is very, very bad for one's brain, and it's much more common than we think it is, and head trauma in IPV is much more common than we think it is. So a lot of our patients are running around with TBIs from IPV that we're not aware of. So preventive script about how you would educate the patient that IPV or unhealthy relationships could play into someone's decision about whether or not to get an abortion.
So maybe I'd say something like, one thing that we know is that someone's home environment can really impact their health and well-being, and wondering if it would be okay with you if I ask you a few questions about your environment and talk a little bit more about whether that might be contributing to your decision to possibly have an abortion.
So awesome, and the preventive universal education folks would say, go the one step further to explicitly mention that that IPV can affect these decision-making processes. So saying, we know that sometimes partners try to actually force you to get pregnant when you don't want to get pregnant. We also know that sometimes partners have very strong feelings about, I think you and I have talked about this before, very strong feelings about whether you should or shouldn't have an abortion, and even try to force you to make a decision that you don't feel comfortable with, right? So you actually have to explicitly tell the person that that kind of thing can happen. And then you can say to them, and if that's ever happening to you, then these are the kinds of things, because you've told me that you want to share with people how you sort of make sure partners don't find out about all that,
I write letters all the time saying, we found that your X, Y, or Z person's pregnancy was not viable, and we therefore provided, a D&C, because they're all non-viable, right? So otherwise we wouldn't be allowed to do them, so I just write these letters all the time.
Yeah. So telling people, so you would even go the one step further, Eleanor, of saying so for
Do you need a
example,
letter?
Well, yeah, for example, if your partner feels very strongly that he doesn't want you to have an abortion, but I just want you to know, first of all, that we will never talk to your partner without your permission, written permission, and that if you need one of these letters, these are the kinds of letters we've provided for people, right? That can make a massive difference in someone's decision, right? Like, because you just said, we know this kind of thing happens. So it's putting out there that we know this kind of thing happens. And then you put that out there, and then you give them the ways that they can get help that don't require them telling you the answer. She could just say to Eleanor, I want one of those letters, right? She doesn't have to say a word about what's happening. Yes, that's helpful to me. Can I have one of those letters?
That makes me think that when we talk to women about medication abortion, we should just put that in there. When you choose to have a pill abortion, it looks to everyone else like you're just miscarrying. So some women,
Absolutely.
find that a pill abortion is really useful when their partner wants
Doesn't
them
want
to
them to have
continue
abortion.
the pregnancy or wanting them to get pregnant in the first place.
Absolutely. That would be
We
an
should probably just
amazing
put that
thing.
in the map thing.
Yeah.
For the real rules about screening, the mandates for screening, does providing universal education live up to those rules? Like, if you don't, are we, in some ways, are we mandated by these rules to actually ask specific questions?
Yeah, and I'm not saying that you shouldn't ask. Like, I actually personally advocate both together. I just say that it's a missed opportunity if you don't provide this education. And I'll say, ironically, I think we're going to get much higher disclosure rates if we provide this preventive education.
I'm just thinking even the
Yeah,
opposite.
but-
Like, if you're in a system where you just don't have the abilities to have those conversations, and you really don't want the MAs or whoever asking the questions,
Uh-huh.
then can you still get credit for providing universal education?
That's not the way it's written. It is written education, screening, brief counseling, referral.
Yeah.
Does it say, if you would like to talk with an advocate about your situation or the situation of someone else you know?
That would be great
I
too.
mean, that would be nice.
That would be
because
nice,
that,
yeah.
it's
Right.
not about you.
Right.
If
Right.
you'd like to see the
Right.
advocate to talk about
Right.
your situation or the situation of someone you're worried about.
Right. And Becky, you're going to hear a million disclosures, right? Because you're like really good at this. You know what I mean? But it's just like not everyone hears a lot of disclosures.
No, right, well, but I think just the way, I don't do the universal education, and I think I think it's true, you probably get much more, you are giving people so much more confidence that you're gonna be able to handle what they say when you do
Right.
that, when you lead with that. I think it just makes so much sense. Whereas the question, especially if the person who's asking it is fumbling through it,
Right.
it
Yeah.
doesn't convey confidence, it doesn't
Right.
give
Right.
confidence. So I think it makes sense to me what you're saying. If you do that approach, you're probably still gonna get more disclosure.
You're going to get more disclosure.
That-
And I always follow it up with a direct question.
You do.
And
So the way
I
you do it is
I
you
do.
start with education, then the
Um,
direct question.
Yeah, and frankly, I'm rushing, and so I often tend to just make it relevant. I literally, my preventive education might be, okay, here, let me pick up one. Patient has insomnia. So I might say to the patient, you've come in complaining of insomnia, and I really want to work with you on that. I do want to let you know that insomnia is often related to stress in your life, and it's very often related to stress in relationships. So one of the things I want to talk to you about is whether your partner ever has hurt you, hit you, or threatened you. So my preventive education, because I only have 15 minutes, might actually be that brief. Like it might just be a couple of sentences, like, this is what you're saying is bothering you. And I want to tell you that sometimes that particular problem, you can relate we could play this lightning round forever. You can, as many things as abusers can think of, and as many bad health outcomes as you can think of a tie-in with any medical complaint.
Yeah.
So it's making it relevant to that person, right?
Trying to link it to dermatology.
Well,
Could have
you could have bruises.
Yes. Yes, you're stumping me, but I bet you I would come up with when you hear a scary diagnosis like this, it's really important that you have someone support you. And if your partner is not supportive, this could be a much harder thing in your life. You can always do it. Okay, how does your partner treat you? Are you frightened? I actually often use the last question for men. What happens when you and your partner disagree, for heterosexual men? Like, what happens when you and your partner disagree? Do you ever get into physical fights? What do your fights look like? Safety should be assessed. We do a really bad job of this. So I have reviewed emergency department charts from our hospital, and I cannot find a mention, actually, and there is no standardized field for weapons involved, yes or no. Once you find out that there is IPV, you need to be asking about how severe it is, whether your partner has ever actually threatened to kill you. Has your partner ever threatened you with a weapon? You need to be asking about this. And then you need to be assessing what is the person's viewpoint about their situation. And it took me 10 years into this work to just be able to sit with someone and say, like, wow, it sounds like you're really in love. You know? And to really be able to sit with that. And I sat with that with a person whose partner had murdered 2 other people before. This is like hard to do. It's really hard to do. Risk factors for lethality. Leaving is one of the biggest risk factors. So another mistake we make in the healthcare system is that we think leaving is a solution. And often leaving is actually the thing that will get someone killed. And so leaving is very, very dangerous and not to be taken lightly at all. And it has to be done as carefully as possible. When someone thinks that you're getting out of their control and they have you under control, that's really, really dangerous. And then I would say perpetrator characteristics. I do ask a lot about the perpetrator. I mean, I write down their description, their social security number, if the person will give it to me. I write down, in case you ever need this in the future, I'll write down these things. But I'm looking for the perpetrator who has nothing to lose. Like in our case of that patient, who he said, I do not care if I go to jail. I don't care if I die. I don't care if you die. Like I have nothing to lose. That is a very dangerous person, right? Everyone had that reaction, and so, and I'm going to give you guys these packets after, but so our safety plan sort of forces you to back up and look at what the patient actually wants. So even for a provider who's not good at this, if you sort of said, and even La Casa uses this all the time, because it's hard for everybody, right, to not want to do something and rescue someone. So conflicting emotions, like can the patient check off all the different things they feel? They feel love. They might feel angry and love at the same time, right? They want the violence to stop. They don't want the relationship to stop, right? So that's a very common thing. And then how do you feel about it? I'm not sure how I feel about this relationship. I think it'll get better. I want to end it. And then danger signs, and then it walks through the safety planning. But really eliciting the patients. We're going to roll this out citywide with mandatory reporting. We're going to add this as an addendum to the mandatory reporting form. If the patient, because we know how sideways the police can go, the police, that's a whole other discussion, but the police are not being entirely honest with us about what they're doing with these mandatory reports, and we think that they're actually probably looking up crimes related to the name of the perpetrator and the victim and trying to solve other crimes that don't relate to the domestic violence. That's what the DV community thinks is probably going on.
Which really, means you need to, right, doesn't surprise us after that case, but also means you have to really counsel the woman very differently than what we've been doing, which is a lot of reassurance about what's going to happen with this report form.
So,
how are you doing
we're
it
working
now?
on it. We're working on it. And the way we're going to write this is like, if the patient wants police help, then fill this out.
I see.
But if the patient doesn't want police help, do not give them these lethality factors.
Well, if she does want it, and you don't have any identifiers.
For the perpetrator, yeah, then it's less easy for them to trace. So the goal is to improve safety. It's dangerous to leave. And then, I think we forget that like actually the perpetrator does wield like power and control, right? Like it is not necessarily totally this woman's own personal choice about what she wants to do, right? She's dealing with the reality of an incredibly dangerous and controlling person. Guilt and shame, I would say, are very, very common, if not universal. So I screen a lot for perpetration too. The perpetrator will present themselves as a victim, and the victim will say that they feel very ashamed of their own behavior. So just that irony there. Really making people feel like nothing they feel. Like that's why I gave voice to that patient when I could hear how much love she had in her voice. I gave voice that like, wow, this sounds like you're really, really in love. And then that broke open this whole story about how this guy has never had anyone supporting him in his life, and he's driven away every single person who ever was in his life, and she felt like she was the one last person there for him. People who are survivors of IPV are profoundly forgiving and generous, wouldn't you say? Like just phenomenally strong. Like we blame the victim and we think this is weak and we're like, why don't you just leave? But people are so generous and strong and loving and like worrying about the perpetrator, worrying about their immigration status, worrying about them losing their job, worrying about them going to jail, like really, really worried about their partners. Often.
Worrying about their kids, losing
Worrying.
their dad.
Absolutely.
It's always so much
Absolutely.
worrying about their kids losing their dad.
Absolutely. So eliciting the patient's perspective, really trying to ask them open-ended questions like, how are you feeling about this? You know, when did you first meet? Like, how has your relationship changed? You know, and again, this might be more the behaviorist and not the clinician who probably doesn't have time to ask a ton of open-ended questions, but at least in the team somehow somebody's talking to the patient about this. And then reflecting and summarizing, you know, like with that patient whose partner had killed 2 other people, I, as hard as it is, I need to say out loud, like, wow, I'm hearing you say that, you know, although he does have a gun in the home, and you just told me that he actually was arrested twice before for killing people, you feel very confident that he's not going to harm you with the weapon. Just like sitting with that, right? And like really, really non-judgmental. And this is from Greg Merrill. Validate and affirm, right? So I just validated and affirmed her even if I disagree, and what Greg says, especially if you disagree. That's really hard to do. And it's the only way that the patient who feels super, super guilty and ashamed is going to feel like this is a space in which they can actually tell you what's really happening, right? They can reveal their most ashamed, most guilty, most deep, dark feelings about this situation because you are not judging. It's hard to do. Yeah. And then if I need to advise, again from Greg Merrill, ask for permission, keep it brief. And so what I say to the patient, would it be okay if I tell you why I'm worried? And patients respond very, very well to, at least, I don't know if with a therapist, you can correct me whether people, like, you know, therapy space is kind of different than a primary provider space. Like primary providers are so bossy all the time. I think patients like expect us to be a slightly more bossy. You know, I'll try to be, I'm trying to get, as I age, like less and less and less and less and less bossy, which is probably nice for my teenagers. Yeah. So like I'll ask the patient, could I share with you why I'm really worried? And then I'll share with them my knowledge of like, well, I'm really worried because although you're saying he's never, you said to me that he's never punched you, what I heard you say, and again using the patient, what I heard you say is that he was driving really recklessly when he had been drinking in order to scare you in the car. And I hear you that you don't think he's going to hit you, but like I'm worried that could be like a really life-threatening situation. And again, like trying not to act super alarmed, right? Like I'm trying to act very, very calm. Because the only way the patient can hear you is if their adrenaline fight or flight is not happening, right? So everybody's got to try and be really calm in interaction.
And the only reporting requirement, Leigh, is visible or like obvious or
Yeah,
injury.
tenderness counts as an injury. If someone says they've been kicked in the stomach and you don't see a bruise, but they're really tender in that spot, forensic people would say that that counts as an injury, but yeah, only injuries are reported.
And are MAs mandated reporters?
Someone on the team has to report it,
If-
and it makes more sense for the team to designate a
Someone
person
besides
who could
the-
do that. So it depends on the clinic. I wouldn't put it on the MAs personally. I feel like they already get less of the positive validation from the patient in terms of the adulation and that type of experience. And so to put like one of the more upsetting tasks onto them, I wouldn't think would be a good idea. The interventions are the whole thing from beginning to end. The education, the empowerment, the options for assistance, the danger assessment, the personalized safety planning, which advocates, DV advocates are way better at than we are at. They do thousands and thousands of these, right? So they're really good at personalized safety planning. Referrals, the case manager, and then the warm handoffs, right? So these things, we're gonna need it all.